Hi everyone, today I'm here with PA Imand, a PA who's been practicing in the field for over 30 years, has been teaching for over 15, and is now a full-time associate clinical professor. Assistant clinical professor. Okay, so first of all, thank you for being with us today and agreeing to this interview.
Pleasure.
I feel like a lot of people are confused on exactly what a physician assistant does. Could you first briefly explain what a physician assistant is?
My career trajectory really followed classically what the PA career field was invented for. So at the end of the Vietnam War in the 60s, a physician named Eugene Stead from Duke University encountered medics, and many of them combat medics, who were returning from the Vietnam War, who came back to the United States with a really incredible skill set, but there was no place for them in the medical field. And really, essentially, the only job they were qualified to do was to be an orderly. Dr. Stead also realized that we were facing, even at that time in the 60s, a impending shortage of providers to provide health care, especially in the field of primary care. So he took those two problems and he came up, really invented the idea uniquely to try to provide some additional training for medics, corpsmen returning from Vietnam, to allow them to provide primary care. And so out of that, the physician assistant program was born at Duke University. The first class graduated in the early to mid 60s. And from that humble beginning, we have now well over 200 programs. And we recently celebrated an anniversary of the field.
I didn't know the history. That's pretty cool. So what's the different scopes of practice between a physician assistant, a physician, a nurse practitioner? Sometimes people might confuse the name with like a medical assistant.
So the initial idea behind the physician, the PA field, was for somebody to work alongside a supervising physician, providing primary health care, whether that was in pediatrics or internal medicine or family practice. But shortly after the advent of the career field, it was also seen that there was going to be a need for PAs to operate in specialty fields. In fact, the majority of PAs currently practicing are practicing in a specialty. Personally, for me, I did 4 years of family practice, went back, did a year of postgraduate training in orthopedic surgery, and then spent over 30 years in orthopedic surgery. Mm-hmm. So it has been estimated that in primary care that approximately 75 to 80% of the task that a physician performs can be performed by a PA. And if you look at the studies that have occurred over the years, many studies have shown that PAs are giving effective, safe, and cost-effective care to patients. The training is significantly less than a physician. Our PA program here at UC Davis in the Betty Irene Moore School of Nursing is a 27-month-long program. The first 12 months are didactic, and it's and it has sometimes been described as kind of the first 2 years elements of medical school kind of compressed within 12 months. Following that, there's an additional 15 months of rotations that our students do in a variety of fields, both primary care and specialty. I would say the major difference between the PA and nurse practitioner fields, and I think our program is unique because we have a combined NP-PA program. So I think that for the faculty here, we're able to really speak directly to what the similarities are and the differences are. And I think there are a lot more similarities than differences. But if I were to highlight some of the differences, it would be that the PA training is firmly based on the medical training model. We're trained similar courses, etc. The program I went to at the University of Oklahoma, in the first year, we took courses alongside the year one medical students, same courses. So that's a difference. The other difference is that when you are entering the field and you're going to be a nurse practitioner, you are really being trained to fill a specific niche. Here at UC Davis, the training is for family practice nurse practitioners. Some nurse practitioners right at the outset go into pediatrics. The PA model is really more based on a generalist model, and then once you complete your training, you can select any field that you want to go into. In fact, some of the data shows that it's not unusual for a PA to change fields of medicine 2 to 3 times over the course of their career. So I would say that would be the big difference, is the portability of the skill set across many different medical specialties.
I have heard that from various people that you can switch specialties a lot easier than going the physician route. How easy is it? Do you just have to do like a residency again, or how does that work?
Good question. So typically in the past, the majority of PAs would just essentially apply for a job. So let's say I'm doing family practice and I decide I want to go into dermatology. Dermatology office is looking for a new graduate or beginning PA. You sign up in the first 6 months. You kind of get integrated in the field. Obviously, then you have to do reading and study on your own. But what has happened more and more is there now has sprung up across the country multiple postgraduate training programs. The one that I went to, I was trained through the military. The military's had them really almost invented the concept of postgraduate training. But you can now go postgraduate training programs in general surgery, urology, orthopedic surgery, emergency medicine, cardiovascular surgery, psychiatry, multiple hem-onc, multiple different, and those usually last about a year, and so those are becoming more popular.
So, do they cover all of the same medical specialties as physicians, or is it just limited to certain ones?
You certainly don't have the breadth and width that a MD or DO would have, in terms of picking a residency. But if you want to call them PA residencies, they're definitely more limited in scope. But more and more opening up each year.
Could you maybe briefly or give us an overview of your path? You said you started, you said later on when you started practicing, you started going into family medicine first and then surgery. Could you kind of walk us through that progression?
Sure. So I was on active duty, and I served as a medic at the end of the Vietnam War. I was in the U.S. Air Force, came back, and the Air Force had a PA program. I applied for that, got accepted, completed it, and then the Air Force has a requirement that when you complete PA school, you're going to start out in family practice, which I think was a really good idea. I'm really happy I did. Because it gave me a appreciation of really a wide variety of medical topics. And the requirement is 2 to 4 years, which most of us did. However, when I was doing my rotations in my second year of school, I was really drawn to orthopedic surgery because I was really involved in sports and I loved going to surgery. So I had the opportunity to apply for the postgraduate orthopedic training program. I did. I finished that in 1989, and then still in the Air Force, went on to finish my career. I retired in 1993, and then worked in the civilian side, private practice, group practice, for the rest of my career.
What was a typical day in your life as a family practice PA and versus an orthopedic practice PA, and how is it different from like the military side to the civilian side? So
I think that really the difference is between military medicine and civilian medicine is really pretty minimal. Okay. We had some other things to worry about, when we took care of the active duty troops. We had training in not only conventional warfare injuries, but chemical, nuclear, biological agents as well. But other than that, medicine is medicine, so it wasn't really different. But when I worked in family practice, we were a fully integrated family practice clinic. So we had an impaneled clinic that my supervising physician and I took care of, and basically for our patient population, we just took care of the entire population. And I think that it's not unlike any field. When you start, Clint Eastwood once said the most important thing is a man's got to know his limitations. So it's not unlike any other field where when you first start out, you're right out of school, and you know what you know, but what you're really afraid of is that you know what you don't know. So in the beginning, you're seeing patients and you're consulting with your supervising physician pretty frequently, But as time goes on, you become more comfortable. Your skill set grows, your experience grows, your knowledge grows. And I would say that at the end of my 4 years in family practice, my supervising physician and I had a relationship where she knew that when I needed her help, I would go and ask her. And like any two human beings, each of us had our individual strengths and weaknesses, and there were some areas in medicine that were of particular interest to me. And to her credit, if she was seeing somebody in that field, she wouldn't hesitate to say, "Hey, Phil, what do you think about this?" in orthopedic surgery, the way that we functioned is we saw a clinic, saw consults, and obviously after doing it for 30 years, I understood when I was presented with something that was out of my scope of knowledge or practice, or when I needed help, and I had somebody to help me. I had a supervising physician, and I didn't hesitate to ask for help. We also ran the inpatient service. We did all the rounding, took care of all the inpatients, and we functioned as the first assist in basically all of the surgeries. So a typical day in family practice would be seeing clinic 5 days a week. Typical day in orthopedics was that there was no typical day in orthopedics. Sometimes you were in clinic. We would do inpatient rounding for a week. We did call, night, weekends, and holidays. And then the OR is highly unpredictable, especially in orthopedics because you're dealing with trauma.
What was the hours in each of those like?
So I think family practice, typically I did not do call when I was in family practice, so it was typically, an 8 to 5 or 9 to 5 job. We did do some urgent care work on the weekends. We would staff a clinic, but in orthopedics, depending on how many people were sharing call, we had call 1 in 8, so 1 every 8 days you were on call, at least until midnight, and could be longer if there was trauma.
How's the lifestyle of a PA different from like a MD, a DO physician, or a nurse? Are they pretty comparable, or? In
terms of the difference between the physician and the PA, the hours are pretty similar, because I think that it's been my experience that you're going to basically structure your hours based on who you're working with, because understand, especially in orthopedics, I mean, it's not like it's 5 o'clock, we're leaving now. We have things that we have to do. So I think that there is a parallel between the lifestyle and the number of hours within a specific field that really is linked between the PA and their supervising physician. I think for nurses, obviously, it depends on where you're working. It could be variable. I do think, though, that one of the advantages that presents for the PA side is that you could work part-time. You could work part-time. It would be hard, especially if you had your own practice and you were a physician, to work part-time. That would be hard to do.
Shifting gears, what was the most challenging aspect of being a PA?
For me, the most challenging aspect was the first 2 years of school, because it was really like having somebody described it as trying to take a drink out of a fire hose. The information was incredible. The program that I was in was highly competitive. It was not only hard to get in, but 40% of our class was not there 6 months after the class started. We had a 40% attrition rate, and it was planned. That was planned. It was in the military. It was pretty brutal.
Okay, what's the most rewarding aspect of being a PA?
The thing that I love the most is that what it presents is it presents you an opportunity to literally practice medicine, but without the investment of the time and the money of years and years and years of training. I feel that I have been put in a position where, because of the training, not only the formal training, but as you probably can appreciate, most of the things that I've learned by working side by side with some incredible physicians. I mean, incredible. And they shared their knowledge, and I'm very grateful for that. And as a result of that, I think it puts the PA in a position where they can make a difference. I mean, I worked urgent care part-time for 13 years, and I can tell you that the clinic that I worked in was staffed by PAs and NPs. And if there weren't PAs and NPs, there was no one else to see the patients, and the patients would not have gotten seen.
What are misconceptions about PAs?
I think that the misconceptions that exist now are fewer. There were a lot of battles that we had to fight going back to the 80s, but the career is now well established. But I mean, initially you'd walk in and the patient would say, what are you? You're a PA? And they kept asking me initially, so are you ever going to finish your training? Are you going to go back and go to medical school? I actually had the opportunity to go to osteopathic medical school, but I couldn't deal with the finances, so that was not going to happen.
Mm-hmm.
I think now what's happening, and the barriers are starting to break down, is some of the governmental regulations, I think, are impeding the ability of the medical environment to use PAs to the fullest of their ability.
How well are PAs compensated generally compared to like physicians or other healthcare providers? And does that vary based on what specialty you're doing?
It definitely varies on what specialty you're in. And it really kind of parallels medicine. You could almost think of it as the PA usually gets. You could almost match it up to say that if Dr. X,
mm-hmm.
whether they're a thoracic surgeon or a pediatrician, is earning a certain amount,
mm-hmm.
then the PA is going to usually will get a percentage of that.
Mm-hmm.
But I will tell you that from recent data that our graduates are able to choose between two to three job
mm-hmm.
offerings,
mm-hmm.
and the starting salary. And now we're talking about somebody right out of school, and the expectation is that for the first year or two, there's going to be a lot of training involved,
mm-hmm.
and you're not going to be at a high level of productivity.
Mm-hmm.
But I mean, you're going to start out upwards of $70,000 a year
mm-hmm.
to start,
mm-hmm.
and there are PAs that I will tell you now that are experienced in surgical subspecialties
mm-hmm.
who are making over $200,000 a year.
What employment types and practice settings are PAs employed in? It seems like you mentioned earlier that they pretty much do every specialty that a physician would do, but it seems like they also have opportunities. Like you mentioned, there are certain clinics where it's like only PAs or NPs, and you said they could also work part-time more easily than like a physician could. So it seems like it's more flexible. Could you kind of talk about what kind of employment settings there are for
Sure.
PAs?
And I think that there's virtually no limit to the imagination that you'll find settings where PAs will work. I was just talking with a colleague the other day who was offered a position to go act as a sole medical provider on oil rigs,
mm-hmm.
either in the Gulf of Mexico or Alaska,
mm-hmm.
and a company contracts out with you, and you go out and you spend a month on the oil rig, and you provide for all the health care for all the personnel assigned to that oil rig. So that's an example. Another example might be, working at an inner city hospital, either employed by the hospital,
mm-hmm.
working inpatient or ED, private practice employees PA. The largest single employer of PAs in the United States is actually the VA medical system.
Mm-hmm.
But I mean, any venue, any location, any type of practice that you can think of, a PA could potentially work in.
Mm-hmm. Okay, and are there tips you'd recommend for PAs to maximize their finances? Are there certain practice settings, or I guess you mentioned like orthopedic surgery or something might have like surgery specialties would have like a higher maybe like bracket?
Yeah.
Are there other things that you could do, or is it more like the more you work is the more you earn kind of thing?
I think obviously the more you work, the more you're going to get. I mean, typically in orthopedics, so in family practice, a typical work week would be 40 to 45 hours. In
mm-hmm.
orthopedics, it could be 60 to 70 hours, depending on how much call you're doing.
Mm-hmm.
And obviously, that time is worth something.
Mm-hmm.
So a thing that limits your amount that you can earn is going to be the amount of hours worked. But it's also going to be the specialty, because really, when it comes down to how much you're able to make, a large function of that is going to be based on how much you're able to bill.
Mm-hmm.
Yeah,
Okay.
And so things like RVUs are tracked very closely, not only for physicians,
mm-hmm.
but for PAs as well.
Mm-hmm. Okay, so generally I would assume more procedures would be more procedure-heavy specialties would be more income as opposed to like counseling or like in family medicine, for example.
Yeah, unfortunately, that's the way it is now. I think things are starting to turn, but reimbursement definitely is procedure heavy at this point.
Mm-hmm. And so I've heard some places or some states are like moving towards giving NPs and PAs more autonomy, and I heard, I'm not sure if this is true, that like Oregon might allow like NPs to practice on their own, and like some places like the pay has been like in Nevada, I heard they might have like made pay comparable like for different specialties for NPs, PAs, and physicians. Is that true, first of all, and do you see that continuing in the future, where perhaps like maybe in primary care or different specialties like NPs and PAs might have their own clinics?
That's a really good question, and it's a hot topic. Mm-hmm. So what's happening right now, the NP career field is well into an initiative where their goal is really independent practice, mm-hmm. to literally be able to open up their own practices, and that's being worked out on the state level, state by state, among the stakeholders. But there are already several states where NPs are allowed to independently practice. The PA leadership has looked at this, has carefully thought about it, and we're now involved in looking at not independent practice, but and I'm actually involved with the politics here in California, mm-hmm. which is a lot like sausage making. Mm-hmm. Yeah, you know what that's about. The end product might be pretty good, but you don't want to know what goes into it. Mm-hmm. So I'm involved in that. So PAs at this point, we are not talking about independent practice, but we are currently working with the state legislature here in California, and each state is working on this, to try to look at some of the barriers that are preventing the delivery of health care. For example, one of the UC Davis program, PA program, one of the things that we're most proud of is that we provide a high percentage of our graduates go into providing medical care for the underserved. Mm-hmm. And there are some clinics, this is not just anecdotal, this is really happening. There are some rural clinics in California where there may be a supervising physician and PAs providing care. Mm-hmm. The supervising physician is older, they retire, and they're struggling to get a new physician in, mm-hmm. to work with the PAs, and the PAs cannot work now, mm-hmm. without legal language of having a supervising mm-hmm. physician. Those clinics have to close. Mm-hmm. There's no medical care provided to that area at that mm-hmm. point. So our state organization is working with the CMA, California Medical Association, and the legislatures to try to figure out common language, some solutions to this problem.
Mm-hmm. Would that be more restricted to certain areas, or how would that come into play, like in practical terms? Would that be like if a physician retires, then that practice setting could still keep going, or would that be like any PA could start their own thing?
That's an interesting question. So the official term for this is OTP, which stands for optimal team practice. Mm-hmm. And I think that the critical thing is to understand that the average PA fully realizes that our relationship that we've had throughout the years, and I'm mm-hmm. going back now over 30 years, and I'm speaking mm-hmm. personally, my relationship that I've had with the physicians that I work with has been awesome. Mm-hmm. It's benefited me, mm-hmm. it's benefited them, and most of all, it's benefited the patients. Mm-hmm. And I don't think any PA is talking about ending that. Mm-hmm. We're not talking about that. Mm-hmm. But what we have to come up with are some solutions to these problems where PAs can't be hired, either because there's a limitation on the number of PAs that can be supervised by a physician, or if they're off-site and their doc retires. We have to figure out solutions. So I don't know what the solution is at this point, but the good news is that we're having productive discussions with the stakeholders.
Okay, and since you mentioned you do work with, like, it seems like you're involved in trying to change policy. I was wondering, how is it easy for PAs to get involved in other things besides clinical practice, and how would they pursue those things? Like, if they're trying to do they do research, or like clinical research or basic science research, or do they do a lot of legislative work? I know a lot of physicians do like other things as well, and is that easy for PAs to do too?
I think that if you have a desire, if you have the ability, the capability, and the will, there's almost no limits. There are many PAs who are in research. Genentech, which is a company right outside of Winters, right off of 505 here, has PAs on staff that work with their research scientists. Mm-hmm. There are some PAs who work mainly in the lobbying career field, mm-hmm. in terms of legislature. There are some PAs that do medical legal consulting. Mm-hmm. So I think there are other, and obviously education is another field, and we need more PAs in education. But I think it's limitless.
You talked about how PA school, at least here in this school, is around 2 years of class-based, or 1 year of class-based, and then
12 months of didactic classroom.
Okay.
And we require everyone who's admitted has to have basic sciences. It's highly competitive to get in. Highly competitive to get in. We just went through the admissions process, and I will tell you that I am blown away by the quality of candidates that are applying now to PA school. 12 months of academic didactic, and then that's followed by 15 months of rotations.
Okay, and is that comparable to other institutions? Like the length of time?
Actually, we're pretty typical.
Okay.
Some might be a little bit shorter, some might be a little bit longer, but we're pretty typical.
And how much does PA school usually cost?
Wow. Wide gamut. Just like any college, some are state schools, there are some private schools, there's some for-profit schools, but you could spend for the program anywhere between $60,000, $150,000, anywhere between there.
What tips would you give, or how would a pre-health undergrad get into PA school? Like, what are the requirements generally? First
of all, I'll tell you there is help. Just as there are pre-med programs at the undergraduate level, there are now pre-PA programs at the undergraduate level. But basically, a bachelor's degree is required. Again, it's highly competitive. And science courses, very similar to pre-med, would include anatomy and physiology, 1 and 2, general chemistry at a minimum. I would recommend that people also take organic chemistry. Biochemistry would be very helpful. Microbiology 1 and 2, very helpful. A medical terminology course would be a really good idea because, as you know, medicine is a different language. It's a different language. Math up to and including calculus, it would be a really good idea. Statistics course is required by many schools. I'm sure I'm missing something. But you can go on any website for any of the programs, and there's some variance. Our program does not require a GRE, but many programs do.
Okay, so there's no like PA CAT or something like the MCAT.
No. Some schools are using the GRE, but there's no. That's a good question. There's no PA CAT at this point.
Okay, and I heard there's a certain amount of clinical hours you need to come in with, right?
Yeah, it varies by program, but that is, I think, what's not unique is across all the PA programs they require a significant investment on the part of the students in patient care.
And how would you get that? Would that be like volunteering at an underserved clinic, or would that be like being an EMT?
The answer is all the above. All the above. Having recently gone through an application cycle, we had we actually had some RNs applying to PA school. We had EMTs, we had paramedics, we had people operating as scribes, we had medical assistants. A wide variety of us. There's a pretty liberal policy in terms of what patient hours apply, but each institution may be a little bit different. And I would recommend if you're looking at an institution that you go on their website.
And is there anything else that you need? Do you need like research or volunteering or other things like that?
I think that like medical school, we're looking at the whole person. So we look at things like community involvement, especially here at UC Davis. We like to admit students that have a heart for serving the underserved and who are committed to diversity. We need to increase our ability to take care of a really diverse medical population, and we just can't afford anymore just to keep graduating one process, all vanilla classes. We need to more mimic what our population that's around us looks like.
With like being a PA or any other healthcare provider, work and life gets pretty intense. How do you establish a work-life balance and prevent burnout?
That's a hot topic. It's interesting. There are many articles written not only about physician burnout, but about PA burnout. For me, I'm kind of still waiting for it to happen. I'm fortunate I didn't get burned out. I think that a lot of it is attitude. I think that if you're going in medicine, whether you decide to go to medical school or you're going to go to PA school, and your goal in life is to make a great living, that sets you up to get burned out. If you go into the medical field and your goal in life is to make a great difference, and I think that's kind of a vaccination. That's kind of a vaccination.
Okay, nice metaphor. The world of medicine is constantly changing. How do you stay on top of all the medical advances, and how would you recommend doing that?
Well, one of the things that really drew me to medicine and that kept me interested is the fact that that you can't know everything, ever. Not ever, not never. You're never going to know everything. As I would drive into clinic and I would think about, my day and seeing patients and the fact that you want to do the best you can for every patient. I mean, my goal every day was I would just pray that I would know enough and know what my limitations are. But just like physicians, it's really critical that you you have to do research. This is not just medicine's not just a job. It's a way of life. You have to be all in. You have to be all in. You have to grow every day. We have pretty stringent CME requirements and recertification requirements. And specifically, we recertify every 2 years by CME, 100 hours, and 50 hours of those have to be Category 1. And then recently, they just changed it. We have to take a recertifying exam, which has been the cause of a lot of anxiety among PAs, because when we take the recertifying exam, we have to recertify in general medicine. So 2 years ago, I had to go in and take a test after 30 years of orthopedics on general medicine. So went to a 5-day review course, did fairly well. We used to have to recertify every 6 years. That's now changed, and you have to take the recertifying test every 10 years. And I should say that upon graduation from PA school, you are eligible to take the initial certifying exam, and you cannot practice unless you pass the exam.
Okay, so it seems like over time there's more and more kind of like tests you have to take.
Every 10 years right now, you have to recertify.
How has medicine changed since you started practicing, and where do you see it going in the future?
I think that the changes in medicine have been influenced, in my mind, by two things chiefly. One's been technology, where there's been all these great advances. I mean, when I started out, we didn't call it MRI, it was NMR, and it was brand new. That's nuclear magnetic resonance. But patients didn't like the word nuclear, so we came up with a different word. It was new technology. At first, we didn't fully understand all the potential applications. I mean, that has changed. There's no limits to technology, but I think the limit's going to be the second factor: finances. I mean, because not everybody's going to get a whole body CT to be sure that you don't have a tiny little plaque growing up in your right carotid artery that's going to be a problem in 30 years for you. So I think the challenge going forward is it would be great if there was unlimited resources and we could do everything for every person all the time. That's not the way it is. We have a pot. We have limited resources, and what we have to do is we have to apply scientific principles to figure out how are we going to get the most bang for our buck. I think that's going to be the biggest challenge.
So resource partitioning.
Yeah.
If you could go back in time, would you change anything about your career path, or do you have any regrets? Is there anything you'd change?
No, I don't think so. I don't think so, and I think that, the reason for that is because there's some pretty big decisions in your life, like am I going to go to college? What am I going to study? Am I going to go to pre-med? Am I going to go to medical school? If I get into medical school and I graduate, what residency am I going to get? And some of those same decisions PAs go through, but I think at each step along the way, fortunately, I had good advice, I had good advisors, I had people around me who came alongside of me that helped me to make an informed decision. And if you have the information, you make an informed decision, then you just go all in and you just commit.
The last question, what advice would you give pre-health professionals to become good healthcare professionals?
I think the first thing is that you have to figure out who you are as a person. Figure out what your motivation is. I mean, I'll be honest with you. In my 30-year career, the people that I have found to be the least happy with what they're doing in medicine, and I don't care what function that they're in, whether they're a radiographer, clinical lab scientist, physician, surgeon, PA, nurse, physical therapist, occupational therapist. The people that I saw who were the most miserable were the people whose primary motivation to get into the field was to make a lot of dough. And some of them were successful, but they weren't very happy. But I think if you look at, if you want to become a PA and you look at this as a way to serve other people, if you have the attitude of servant or servant leader, then this field is not going to be disappointing to you.
Mm-hmm. So focus on the intrinsic motivators.
That's what I think.
Mm-hmm. Great.
Yeah. Be a better person,
mm-hmm.
and you'll be a better provider.
Mm-hmm. Great advice. So thank you again, PA Iman, for being with us today. Thank you guys for watching. If you have any questions about physician assistant programs, let me know down below in the description. I could ask PA Iman and get back to you. Thank you guys again for watching. Have a good rest of your day.
Happy New Year.